Welcome to the deep dive.
Yeah.
Now, if you hear the word diabetes, I bet your mind immediately jumps, quite understandably, straight to blood sugar.
Right. Insulin, glucose monitors, type 1, type 2.
Exactly, all that. The huge global health challenges we know as diabetes mellitus.
And yeah, that association makes sense for millions of people. But today, we're doing a sharp pivot. We're going way off the glucose path.
We are. We're diving deep into a condition that, confusingly, shares that exact same ancient name.
And the exact same main symptom, that excessive urination.
But it has absolutely nothing, zero, to do with sugar or how your body uses carbs.
We are talking about diabetes insipidus, DI for short.
Right, DI. And our mission today is really to unpack this. How can a failure in managing water, something so fundamental, how can that look so much like a sugar disease?
We need to pull out the facts that really separate DI, understand its roots, which are hormonal, deep in the brain and kidneys.
And explore what happens, the kind of dangerous relationship the body gets into with water when that hormonal control just fails.
And you know, that word diabetes, it's old. It comes from Greek.
Meaning?
It means to pass through, basically describing that huge flow of fluid, the urination.
Okay, so that's the link. That's what they share.
That's the shared symptom. But the why in DI is completely different. It's a fundamental breakdown in the body's water-saving system.
Leading to this awful cycle of just relentless thirst.
Polydipsia, yeah, and constant excessive urination. Polyuria.
Now, this might sound, like a really rare thing compared to diabetes mellitus.
It is rarer, definitely. But it's not insignificant. We need to get a sense of the scale. It's a major life-changing diagnosis. We're talking hundreds of thousands of people worldwide dealing with this.
Right. And you gave a figure for the UK alone earlier.
Yeah, estimates are around maybe 2,000 to 3,000 people just in the UK, and they are living with this daily struggle.
It's not just like needing the bathroom more often, is it?
Oh, absolutely not. Think about it. The constant, urgent need for water, the constant need for a toilet nearby, it massively disrupts sleep, work, social life, everything.
It's a fundamental hit to your body's balance, its homeostasis.
Exactly, which is why getting into the mechanism is so critical.
Okay, so we've established two conditions, same name, same passing through symptom. Let's really dig into the mechanics now. What makes them biologically distinct? This naming confusion, sugar water versus salt water.
That really is the heart of it. So let's start with the familiar one, diabetes mellitus.
The sugar one.
The sugar one. The problem there is glucose. Too much of it building up in the blood.
Because either the body isn't making enough insulin,
Type 1.
or the body's cells are just ignoring the insulin that is there.
Type 2. Insulin resistance. So the sugar stays stuck in the bloodstream.
Right.
And the kidneys, there are filters. They see all this excess glucose and they try to get rid of it. They dump it into the urine.
Okay, but that dumping has a consequence.
A huge one. Glucose is what we call osmotically active. It's like a sponge for water.
So wherever the sugar goes.
Water follows aggressively. The sugar literally pulls large amounts of water out of your body tissues and into the urine along with it.
So the massive urination in DM is actually a side effect of the body trying to ditch the excess sugar.
Precisely. It's secondary to the glucose problem.
And that directly leads to that memorable, if slightly gross, historical diagnostic technique.
It does, and it's memorable for a reason. It perfectly highlights the difference. You hear stories about Hippocrates or maybe later physicians in Greece or India.
Doing what? Tasting the urine?
Allegedly, yes, because the urine of someone with untreated diabetes mellitus would taste sweet. All that excreted glucose.
Which is where the name comes from, diabetes mellitus.
Exactly. Mellitus meaning honeyed or sweet.
Okay, that definitely sticks in the mind. But hey, was it always just sweet? I seem to remember something about ketones, too, especially in type 1.
That's a really good point. Yes, while the sweetness is from the glucose, if it's severe untreated type 1 DM, the body gets desperate for fuel. It starts burning fat like crazy.
And that produces ketones.
Right, ketone bodies like acetone. And then that can give the breath and sometimes the urine a sort of fruity or almost nail polish remover smell. But the reason for the excessive water loss, the urination itself, is still that osmotic pull from the glucose. That's the key difference from DI.
Okay, so DM is the sweet one. Let's pivot back fully to our main topic today, diabetes insipidus.
Insipidus literally means tasteless. Because the urine in DI isn't sweet. There's no excess sugar being dumped. It's incredibly pale, very watery, very diluted, Lacking flavor, you could say.
Because this disease has nothing to do with blood sugar control.
Nothing at all. It's purely about hormonal control over water balance, pure water.
So the symptom looks the same, needing to pee constantly, huge volumes, but the cause is flipped. Instead of sugar pulling water out,
The body has failed to get the message, or failed to act on the message to keep water in.
the kidneys just let it all go.
Right. Their ability to conserve water is essentially switched off, no matter how dehydrated the person might be. And this is why understanding the difference is so important for you listening.
Yeah.
Because if you or someone you know has that persistent extreme thirst or constant urination, just checking blood sugar isn't enough. It could be this other system failing.
A failure in that really fundamental survival mechanism, water conservation.
Exactly.
Which brings us then to the absolute core of this, the hormonal system that should be managing all this. Let's dive into arginine vasopressin.
AVP.
AVP, that's the star hormone here. You might also know it as ADH.
Antidiuretic hormone.
Right. Diuresis means increased peeing, so antidiuretic is the signal to, well, stop peeing so much.
The body's water conservation chief.
Pretty much. Its job is to maintain the right balance, the right concentration, the osmotic pressure of our blood.
And where does this crucial messenger come from? It's made somewhere pretty sensitive, right? In the brain. Deep in the brain, yes. It's a multi-step process. The hormone itself, AVP, is actually made in specialized nerve cells. These are mainly in clusters called the supraoptic and paraventricular nuclei.
Which are located where?
Deep inside the hypothalamus. That's a really key brain region. Think of it as the body's control center for temperature, hunger, and importantly here, for monitoring how concentrated our blood is.
So the hypothalamus is the factory.
Mm-hmm.
But what tells the factory, hey, start making more AVP?
Excellent question. It's all about sensors. The hypothalamus has these specialized sensors called osmoreceptors.
Osmoreceptors, okay.
They constantly taste the blood, essentially. They monitor its concentration, its tonicity. So if you start to get even a little bit dehydrated.
Meaning your blood gets a bit too salty or concentrated.
Exactly. Those osmoreceptors immediately detect that change, and they signal the hypothalamus, we need more AVP now.
The alarm bell rings if the blood gets too thick.
That's a good way to put it. So AVP gets made. Then it travels down long nerve fibers, axons, from the hypothalamus to another structure right underneath the brain.
The pituitary gland.
Specifically, the posterior pituitary gland. It sits right at the base of the skull. This is the storage depot and the release site.
Okay. Factory in the hypothalamus, storage and release in the posterior pituitary.
Correct. When that dehydration alarm sounds, the posterior pituitary gets the signal and releases the stored AVP directly into your bloodstream.
The message is out, it's traveling. Now the crucial part, how does AVP actually get the kidneys to save water? This seems like where things can really go wrong in DI.
This is absolutely critical. We're moving from brain anatomy to kidney plumbing now.
Right.
AVP circulates in the blood until it reaches the kidneys. It specifically targets the very last part of the kidney's filtering tubules. These are called the collecting ducts.
Collecting ducts, got it.
And on the cells lining these ducts, there are specific docking sites, like little keyholes for AVP. They're called V2 receptors.
V2 receptors. So ADP arrives, fits into the V2 keyhole. Then what?
That docking action triggers a whole chain reaction inside the kidney cell. It sets off a signaling pathway, and the end result is the insertion of special water channels into the cell membrane.
The membrane facing the urine that's about to leave the body.
Exactly. These channels are called aquaporin 2, AQP2.
Aquaporins. I've heard of those. They're like actual tiny tunnels just for water molecules.
Precisely what they are, tiny specific water tunnels. Think about this. Your kidneys filter something like 180 liters of fluid every single day.
Wow.
But obviously you only pee out maybe, what, 1.5, 2 liters?
Right.
That's because of these AQP2 channels. When AVP gives the command, these tunnels get inserted, and they allow almost all that water, like 99% of it, to be rapidly pulled back out of the collecting duct and returned to your bloodstream.
It effectively turns the tap off at the last second.
It turns the tap off, saves the water, and makes the urine more concentrated. Brilliant system.
Hugely efficient, fine-tuned. Okay, so that's how it should work. What happens when this multi-step essential system breaks down?
The consequences are immediate. and dramatic. If there isn't enough AVP being made or released, or if the kidneys can't respond to it,
Then those aquaporin 2 channels.
they don't get inserted, or not enough of them do.
Eh?
The collecting duct stays waterproof, essentially, impermeable to water.
So the water just flows right out.
It rushes out. It cannot be reabsorbed no matter how dehydrated the person is. The signal to save water is lost.
Leaving the person constantly thirsty, constantly dehydrated, that vicious cycle you mentioned.
Exactly.
How much fluid loss are we talking about here? Is it just a bit more than usual?
Oh, no, it's massive. We're talking 5 liters a day on the low end for someone with DI.
5 liters, that's over a gallon.
Easily. And commonly, patients can excrete 10, 15, even up to 20 liters of this incredibly dilute, pale urine every single day.
20 liters, that's like 5 gallons. Imagine having to drink 5 gallons of water just to keep up and still feeling desperately thirsty.
That is the brutal reality of living with diabetes insipidus.
Okay, and here's where it gets, as you said, really interesting. Because this system can fail in different ways, right? In different places along that chain, from brain to kidney.
Exactly right. There are 3 main ways this AVP system can break down, leading to the 3 main types or faces of diabetes insipidus.
Let's break them down. Type 1 seems like the most straightforward, maybe. AVP deficiency. Used to be called central DI.
Yeah, central because the problem originates in the central nervous system, the brain. This is basically a supply problem.
Meaning the hormone factory or the delivery truck is broken.
Perfect analogy. The kidneys, the receiving end, are perfectly fine. They're waiting for the AVP signal ready to respond, but the signal just isn't being produced correctly by the hypothalamus, or it's not being released properly by the pituitary gland.
And the things that can cause this failure,
Yeah,
they really show how vulnerable that area of the brain is.
they do. Because the hypothalamus and pituitary are nestled right there at the base of the brain, they're susceptible to damage.
Like from what?
Well, common causes are things like brain tumors pressing on the area, or significant head injuries, or sadly, sometimes complications from brain surgery in that region. Any physical disruption can damage those crucial AVP-producing cells or the pathways.
Makes sense. But it's not just physical trauma. You mentioned infections earlier, which was surprising. Syphilis, tuberculosis. How do they cause DI?
It comes down to where the infection can take hold. In their later stages, both syphilis and TB can cause chronic inflammation or growth granulomas, particularly at the base of the brain.
Right near the hypothalamus and pituitary.
Exactly. This inflammation can physically damage or destroy the nerve cells that make AVP or the nerve fibers that transport it down to the pituitary for release. The infection essentially severs the connection.
Wow. Okay. And sometimes you just can't find a cause, right? It's called idiopathic.
That happens too, yes. Sometimes the cause remains unclear after investigation, but there's another cause, a really fascinating one that's temporary.
Ah, the pregnancy-related one. Gestational diabetes insipidus.
That's the one. It's not about damage. It's about biochemistry during pregnancy.
And it's the placenta doing something weird.
It is. Usually in the 3rd trimester, the placenta starts producing large amounts of an enzyme. It's called vasopressinase.
Vasopressinase. So it breaks down vasopressin.
Exactly. This enzyme floods the mother's bloodstream and rapidly breaks down her AVP before it can even reach her kidneys to do its job.
So her body is making AVP, but the placenta is just neutralizing it immediately.
Like a biological counterattack, which explains why it's temporary.
Right. Once the baby is born and the placenta is delivered, the enzyme source is gone, and the DI usually resolves pretty quickly.
Correct. Now, the good news for AVP deficiency DI, whether it's permanent from damage or temporary from pregnancy, is that the treatment is relatively logical.
Because the kidneys are still listening. If the problem is just a lack of the hormone,
Then you replace the hormone.
simple as that.
Pretty much. We use a drug called desmopressin. It's a synthetic version of AVP designed to be more resistant to breakdown.
And it works just like the real thing.
It binds effectively to those V2 receptors on the kidneys' collecting ducts, triggers the aquaporin insertion, and tells the kidneys to conserve water.
How do patients take it?
There are options. It comes as a nasal spray, which is common, or as tablets, or sometimes an injection.
Okay, so that sounds like a fix. But is there a catch? Managing hormone levels seems tricky.
There is a significant catch, and it highlights the danger again. AVP, or desmopressin, is powerful stuff. If a patient takes even slightly too much,
They hold on to too much water.
exactly, they swing the other way, their body retains excess fluid, and that dangerously dilutes the sodium in their blood.
Which is that condition hyponatremia we need to talk more about.
Yes, it can happen very quickly with overtreatment. So patients on desmopressin have to be incredibly careful. They need to constantly balance their dose with how much they drink, paying close attention to their thirst and how much urine they're producing. It's a constant juggling act.
A demanding condition even with treatment. Okay, let's move to the second type. Type 2. AVP resistance. Used to be called nephrogenic DI.
Nephrogenic, meaning originating in the kidney. So if type 1 was a supply problem.
Type 2 is a reception problem.
Yeah.
The message is being sent, but the kidneys aren't listening.
Precisely. The brain, hypothalamus, pituitary, is working fine. It's pumping out AVP, often in high amounts because it senses the dehydration. The hormone is circulating in the blood.
What?
But the kidney cells, specifically those V2 receptors on the collecting ducts, are unresponsive. They're broken or blocked or just ignore the AVP signal completely.
So those aquaporin water channels never get put in place.
Correct. The command is shouted, but the door stays locked. Water flows right out.
So what breaks the receiver? Is it something you're born with or something that happens later?
It can be both. There's a congenital form, often genetic, sometimes X-linked, meaning it runs in families. But acquired nephrogenic DI is actually more common.
Acquired how?
Often it's the result of chronic kidney damage itself. Things like long-term severe imbalances in electrolytes can damage the kidney tubules.
Electrolytes.
Specifically, sustained high levels of calcium in the blood hypercalcemia or very low levels of potassium hypokalemia. Both can impair the kidney's ability to respond to AVP over time.
Okay. And this is the type that has a strong link to certain medications,
A
right?
very strong link. The classic example is lithium.
Lithium used for bipolar disorder.
Yes, a cornerstone treatment for bipolar disorder, really effective for stabilizing mood.
Yeah.
But it has this known significant side effect on the kidneys.
How does lithium cause AVP resistance?
Over time, lithium can actually enter the cells of the collecting duct and interfere directly with that signaling cascade that happens after AVP binds to the V2 receptor. It essentially jams the internal machinery needed to get those AQP2 channels to the surface.
Wow. So it blocks the process from the inside.
It seems to, yes, leading directly to AVP resistance or nephrogenic DI.
That is a really difficult situation. A medication needed for mental health causing a serious physical disorder. How is that managed for patients on lithium?
It requires really close monitoring. Anyone on long-term lithium needs regular blood tests, not just checking the lithium level itself, but also checking kidney function things like sodium levels and how concentrated their urine is.
And if DI develops?
Then the doctors face a tough choice. They might try adjusting the lithium dose or consider other mood stabilizers if possible, but often it's about managing the DI while trying to maintain the essential psychiatric treatment. It's a real balancing act.
Okay, so for this type 2, giving desmopressin, the synthetic AVP.
That's pointless, right? The kidneys are deaf anyway.
Completely pointless. You can flood the system with AVP. It won't make a difference if the receptors aren't working.
So how do you treat that? This is where it gets weirdly counterintuitive, isn't it? Using diuretics. Drugs that make you pee more.
It sounds totally backwards, I know, but it's actually quite clever based on understanding kidney physiology deeply.
Explain this one slowly. How does making someone pee more help stop them from peeing too much? Okay, so the problem is the final segment, the collecting duct, isn't reabsorbing water. So the strategy is to make the kidney reabsorb less salt and water much earlier in the filtering process, further upstream.
Upstream, like in the earlier tubules.
Exactly. We use a class of diuretics called thiazides. These drugs work higher up in the nephron, causing the body to lose a bit more sodium and water there.
Which creates a mild state of dehydration or volume depletion.
Sort of, yes. It gently reduces the body's overall fluid volume, and this tricks the body into thinking, whoa, I really need to conserve fluid now.
And how does the body respond to that trick?
It tries to compensate by increasing the amount of water and sodium it reabsorbs in the very first part of the kidney tubule system, the proximal tubule, long before the fluid ever gets to the broken collecting duct.
So by forcing a bit of loss early on, you make the body grab back more fluid even earlier, meaning less fluid actually reaches the faulty collecting duct at the end.
You've got it. Less fluid arrives downstream, so even though that final segment is still broken and can't concentrate urine, the total volume of urine produced is significantly reduced.
It's like reducing the pressure on the leaky part of the pipe by turning down the main valve slightly.
That's a great analogy. It's an indirect but effective way to manage the water loss.
Clever. Does it require anything else?
Yes. This strategy works best when combined with a very low salt diet, and sometimes a low protein diet too.
A low salt.
Because less salt intake means less solute load for the kidneys to handle overall, which further helps reduce urine output when using thiazides. It's a combined approach.
Complex management for a complex problem.
That's so.
Okay, we've done the supply problem, type 1, and the reception problem, type 2. What about type 3? Dipsogenic diabetes insipidus. This sounds different again, like the brain's thirst control is messed up.
Exactly. This isn't really a problem with AVP production or kidney response initially. This is a problem with the thirst gauge itself. The primary driver is abnormal excessive thirst.
And where is this thirst gauge?
It's also located in the hypothalamus, right near where AVP is made and where those osmoreceptors are that monitor blood concentration.
So damage to that specific spot, again, from things like tumors, head trauma, infections, maybe surgery?
Yes, damage right there can essentially reset the thirst mechanism incorrectly. It dramatically lowers the threshold at which you feel thirsty.
Meaning the person feels desperately thirsty even when they're not actually dehydrated.
Or worse, even when they are already overhydrated, they have this insatiable pathological urge to drink water far, far beyond what their body actually needs to maintain balance.
That sounds incredibly difficult to live with. And it sets up a dangerous loop, doesn't it?
A really vicious cycle. Okay, so the person feels pathologically thirsty, so they drink huge amounts of water. Let's say their AVP system was actually working fine to begin with.
What happens then?
Well, the brain correctly senses this massive fluid overload from all the drinking. And what's the normal response to fluid overload?
Stop releasing AVP to let the excess water out.
Precisely. The constant excessive drinking suppresses the natural release of AVP down to zero. So now you have two problems: the pathological drive to drink and the body shutting down its water-saving hormone in response.
Which just makes them pee out everything they drink, probably making them feel even thirstier.
It reinforces the cycle. And this constant flushing of the system with massive volumes of water leads directly to the most acute danger we've mentioned: hyponatremia.
Diluting the blood sodium. Let's really unpack why that's so bad. Sodium isn't just table salt, right? It's critical.
Absolutely critical. Sodium ions are fundamental for nerve function, for sending electrical signals, action potentials. They're vital for muscle contraction, including the heart. Our entire nervous system runs on carefully controlled sodium gradients.
So when someone with dipsogenic DI, or any condition causing massive water intake, drinks, say, 10, 15 liters of plain water a day,
They are literally washing the sodium out of their body fluids. The concentration of sodium outside the cells plummets.
and water moves.
Where? Water always moves to try and equalize concentrations. So if the fluid outside the cells becomes too dilute, water rushes into the cells to try and balance things out,
Including brain cells.
including brain cells. And when brain cells swell with excess water, that's called cerebral edema. That's incredibly dangerous because the skull is a fixed box.
Pressure builds up.
Pressure builds up, leading to severe headaches, confusion, nausea, vomiting, and in the worst cases, seizures, coma, and even death.
Just from drinking too much water, driven by a faulty thirst signal. Wow. This sounds like it must be really hard to distinguish from certain mental health conditions.
It is notoriously difficult. This brings us right to the overlap between this type 3 dipsogenic DI and a condition called psychogenic polydipsia, PPD.
Polydipsia just means excessive thirst. So PPD is thirst driven by the mind. Psychological causes.
Essentially, yes.
Yeah.
PPD is compulsive water drinking. That's often seen in patients with severe mental health disorders, classically schizophrenia, but also sometimes in affective disorders or even due to certain medication side effects like extreme dry mouth.
But the behavior drinking massive amounts of water looks the same as dipsogenic DI.
Exactly the same. And the physiological result is also the same. Huge water intake suppresses AVP release, leading to massive output of dilute urine and that same dangerous risk of hyponatremia from sodium dilution.
So how on earth do doctors tell them apart? If someone comes in drinking 15 liters a day, is it neurological damage to the thirst center, dipsogenic DI, or a psychiatric compulsion, PPD?
It's a major diagnostic challenge. The gold standard often involves a carefully monitored fluid deprivation test in a hospital setting, watching how their body responds when water is restricted. But clinically, sometimes there are subtle clues.
Like?
In PPD, the compulsive drinking might sometimes be distractible or fluctuate with their mental state. Patients might sometimes be able to resist the urge for a period. In dipsogenic DI, the thirst is often described as more constant, overwhelming, a truly physical, neurological craving they cannot ignore. But it's tough to differentiate.
And the treatment must be completely different depending on the cause.
Fundamentally different. If
Yeah.
it's PPD, the core treatment is managing the underlying psychiatric illness, perhaps with medication adjustments, therapy, behavioral strategies.
Okay. But if it is dipsogenic DI, the faulty neurological thirst gauge, what do you do then? You can't give desmopressin, right?
Absolutely not. Giving desmopressin would be incredibly dangerous. It would force the body to retain all that water they're compulsively drinking, leading to rapid, severe hyponatremia.
So what can you do?
The primary treatment is actually behavioral. It involves strict, supervised fluid restriction.
You have to limit their water intake even though they feel desperately thirsty?
Yes. Under very close medical supervision, usually in hospital initially, to monitor their sodium levels constantly. The goal is to slowly normalize their blood sodium while helping them manage the intense sensation of thirst. It's incredibly challenging for the patient and the healthcare team.
Wow. That sounds grueling. You mentioned an extreme case earlier, someone drinking 15 liters.
Yes, and that case really underscores the potential catastrophe. A young patient suffering seizures and severe neurological complications directly because of that level of water intake, nearly 4 gallons a day.
It really drives home the point.
Yeah.
Water is essential, obviously, but there's a limit. Too much pure water becomes toxic.
It absolutely does. Pure water intoxication leading to hyponatremia and brain swelling.
And this pathological need to drink contrasts so sharply with, the world we live in now where we're constantly told, hydrate, drink more water.
It's a strange paradox, isn't it? There's good general advice out there. Staying hydrated helps prevent constipation, kidney stones, maybe helps concentration. That's all true within reason.
But then you see these extreme recommendations.
Right. Like the example you cited, Tom Brady apparently recommending around 2 gallons, that's nearly 8 liters a day. Now, he's an elite athlete with huge fluid losses, but for the average person,
8 liters is a lot of water if you're just sitting at a desk.
it's potentially excessive and unnecessary for most people. And this is the really crucial, nuanced takeaway for everyone listening about hydration.
What's the bottom line?
Your body is incredibly smart. It has this sophisticated AVP system. It has thirst signals. It has osmoreceptors. Trust those signals. Drink when you are thirsty.
Don't force it.
Don't force huge volumes, especially if you don't feel thirsty. And critically, if you do feel constantly intensely thirsty or find yourself compulsively drinking large amounts day after day, that is not healthy hydration.
It's a warning sign.
It's a massive red flag. It's telling you something is fundamentally wrong, maybe hormonal like DI, maybe neurological like dipsogenic DI, maybe psychiatric like PPD. Trying to treat that pathological thirst by just drinking more water is often the absolute worst thing you can do.
Seek medical advice instead.
Okay. Let's try and tie this all together now. If we had to boil down the absolute core difference between the two conditions called diabetes, what's the key takeaway? Diabetes insipidus, problem with the AVP hormone system or kidney response, leads to inability to save water. Urine is dilute, tasteless, nothing to do with sugar.
Diabetes mellitus.
Yeah.
Problem with the insulin system and glucose. High blood sugar pulls water out osmotically. Urine is sweet, contains glucose.
That's the fundamental split, water management versus sugar management.
And why has this deep dive been important for you, our listener?
Because diabetes isn't just one thing. Understanding DI adds crucial context. It means recognizing that some things like excessive thirst and urination aren't always about blood sugar. They could point to this entirely different, serious hormonal axis failure.
And knowing this broadens the possibilities when someone presents with these symptoms.
Absolutely. And it highlights the real impact on quality of life. Think about the constant planning around bathroom access, the sleep disruption from waking up to drink and pee, the anxiety. It's relentless.
So the call to action is clear.
Crystal clear. If you or anyone you know experiences that persistent, unexplained, excessive thirst, or is drinking huge amounts of water and urinating constantly, don't ignore it. Don't just assume it's nothing or try to manage it yourself. Get it checked out by a doctor, promptly.
Because it needs proper investigation to figure out the underlying cause.
It really does. And maybe the ultimate lesson here, connecting it all, is just how interconnected our body systems are. A simple symptom like thirst can be a signpost pointing towards issues with sugar metabolism or hormone production or kidney function or brain signaling or even mental health.
The body speaks in complex ways.
It does. We just need the knowledge to interpret its language.
Okay, as we wrap up, We always like to leave you with something a bit more provocative, a final thought to mull over.
All right.
We spent some time on type 2DI AVP resistance. The kidneys ignore the AVP signal, often due to damage, maybe from medications like lithium.
Right, and treatment is tricky, indirect, using diuretics and diet, because just giving more AVP doesn't work. The receiver is broken.
But we know the specific failure point inside the cell is often related to getting those aquaporin 2 water channels inserted into the membrane. The V2 receptor signal isn't making it happen.
Yes, the downstream plumbing is blocked.
So consider this. What if future drug development could sidestep that broken V2 receptor entirely?
How do you mean?
Could we design, say, small molecule drugs that could get inside the kidney collecting duct cell and directly trigger the insertion of those AQP2 channels? Or maybe act even further down the line to keep the channels that do get inserted active for longer?
So you're talking about bypassing the faulty receptor and directly activating the water channels themselves, or the machinery that puts them in place.
Exactly. Fixing the plumbing failure from the inside regardless of whether the initial AVP signal is heard or not. Could that offer a more direct, maybe more resilient treatment for those tough AVP-resistant cases?
That's a really interesting thought. Moving beyond hormone replacement to targeting the specific cellular mechanics of water transport, that would be a fundamental shift in treating nephrogenic DI.
A potential future where we can directly tell the kidney cells to save water, even if they can't hear the brain's instructions. Something for the researchers to work on.
Definitely a fascinating challenge, solving the riddle of tasteless diabetes at the molecular level.
Well, thank you for guiding us through this deep dive into water, hormones, and the surprising, sometimes dangerous world of thirst.
My pleasure. Until next time.